Good morning, everyone, and welcome to the postgraduate combined rounds. Today we have two special guests, Dr. Catherine Nelissen from Hasselt University in Belgium. She is a PhD in Biomedical Sciences and the Faculty Administrative Director. And Professor Leen Poplew, she is a professor in anatomy and the head of Bachelor of Medicine. In Belgium, the medical graduation is in two parts. The first part is 3 years Bachelor in Medicine. So she is the head of the Bachelor of Medicine program. And then they have a 3 years Masters in Medicine, which completes the medical graduation. So that is what is equivalent to our MBBS. And the purpose of their visit is to renew a memorandum of understanding, which we already had with them earlier when Dr. Saxena was the Pro-Vice Chancellor and Dr. Swati was the principal, under which some of their students came and did an observership with us. So in between, because of COVID, there was a disruption. So they have come back again to discuss with us whether their students can come again. And in all likelihood, if things take shape, then their students will come to us again sometime next year for an observership. Also, at the end of the PGCR, the team is going to make a short presentation about what their research interests are in the university, so that the faculty can think of some possible collaborations under various Indo-Belgium programs of UGC, DST and other scientific agencies. So welcome. And now I would request Dr. Mukesh Sarna. Dr. Mukesh is a professor of medicine. He is a fellow of the Royal College of Physicians, and he is the convener of this postgraduate combined rounds. Dr. Mukesh, please.
Thank you, sir. Good morning, respected dignitaries, our guests from the Hasselt University from Belgium, respected teachers, dear students. To master the basics for academic brilliance, a series of postgraduate combined rounds were started, and on different topics with involvement of the different faculties or different departments. And topics like what it takes to be a good resident, jaundice, anemia, stress in healthcare workers, how to present a oral presentation, and how to make a PPT, and dyspnea, jaundice, pain. These topics were covered in earlier postgraduate combined rounds. Postgraduate combined rounds have two groups, like core group and review group, and they review the presentation before the students and moderator present here. And this is the 11th postgraduate combined round, and it's almost 1 year now we have started. We have different other combined rounds like nursing combined rounds, clinical combined rounds, in addition to this postgraduate combined rounds. As we all know that the blood transfusion is an important daily activity in the life of a physician or doctor. To discuss the different aspects of blood transfusion, today's PGCR of good transfusion practices has been planned, and this will be the part 1 of the series of good transfusion practice PGCR. The chairperson for today's PGCR are Dr. Rachna Narayan ma'am, and she is the head of the IHBT department, and Dr. Ashwini Mathur sir, he is the head of the department of orthopedics. Now I'd like to invite Dr. Rachna Narayan ma'am to give a brief overview of IHBT department.
Good morning, dignitaries, my fellow professors, students. We are here today to apprise the basics, very basics about the transfusion. To start with, it's a long story. From the day the college was established, we had to take a license to run the blood bank. From that to recent, we have 2 students in MD and even 2 PhD students. To cut it very short, we have all the required accreditations, regulations from the Government of India, Drug Controller, NACO. From time to time, as you can see in this, it took a long journey through This is the total number we perform in yearly manner, which is increasing day by day. As we all know, Mahatma Gandhi now has plenty of transplants. For example, each liver transplant takes away around 40 to 50 units in one go. So the number is increasing gradually day by day. These are various facilities available in our department. The labs, equipments. I would wish each one of you to come and have a look and just see the functioning and be aware about it. These are certain specialized. For example, you must have heard about SDP, how to take SDP. These are various machines on which we do SDP, therapeutic plasma exchange, and granulocytes, peripheral blood stem cells. For testing, I think by now each student knows what is net testing and specialized testing by Luminex, flow cytometry for solid organ transplant, and also we make various components. This entire subject, I should say, is too vast, so we have decided to put it in two parts. We'll go very gradually. Bear with us.
Thank you very much, ma'am. A very good morning to respected dignitaries, respected faculty members, respected seniors, and my dear colleagues. I, Dr. Nisha Raj, welcome you once again to the 11th PGCR, starting with today's presentation. Good transfusion practices. Transfusion medicine is a multidisciplinary science concerned with the proper use of blood or blood products in the treatment or prevention of disease. Good transfusion practices ensures that the right blood is given to the right patient at the right time. And these three main points will form the basis of our presentation today. Starting with the history of blood transfusion, this dates back about 400 years. In 1665, Richard Lower was the first scientist to attempt animal-to-animal blood transfusion. The next was 2 years later in 1667 when Jean Dennis was the first scientist to attempt animal-to-human blood transfusion. Then after a hiatus of a few years, in 1818, it was James Blundell who attempted the first human-to-human blood transfusion. But the actual breakthrough came only in 1900 when Karl Landsteiner discovered the ABO blood group system, and based on this discovery, the first pre-transfusion cross-match was done in 1907. We know that blood cannot be manufactured, and every 2 to 3 seconds somebody is requiring blood in India. Hence, any blood center is dependent on their blood donors to maintain its supply. I would now like to walk you through the process of blood donation. It includes 4 stages. The first stage is pre-donation information and an option of self-referral. The second stage includes pre-donation counseling, physical checkup and selection by the doctor, and also an option to opt out. Here, the doctor selects whether the donor is fit to donate or not donate. The third stage includes blood donation and testing of the collected blood. There are 5 mandatory tests that we follow, that is HIV, HBsAg, HCV, syphilis and malaria. These tests are mandatory for transfusion transmitted infections. If at all any of these comes positive, the donor is referred to the concerned department for follow-up and the blood gets discarded. Once the donation process is over, the donor is sent to the donor recovery area where he is provided with refreshment, and post-donation counseling, we are giving coffee in the form of refreshment. Now, as I discussed the blood donation process, I would also urge you all to please come forward and donate. And now there's a question, who can donate blood? So an individual with normal blood pressure and hemoglobin levels, that is a hemoglobin level of 12.5 gram per DL and above, a systolic blood pressure of 100 to 140 mmHg and a diastolic blood pressure of 60 to 90 mmHg. An individual who is between the age group of 18 to 65. Actually, if you are donating for the first time, the age group is 18 to 60 years, and if you are a repeated donor, the age group increases to 65 years. An individual who has a weight at least 45 kg, an individual who has never been infected by HIV, hepatitis B, hepatitis C, an individual who is not on certain medication, has had a good night's sleep, has had something to eat in the past 4 hours, is not on any medication, can safely donate blood. Now you can appreciate in this picture the process of blood donation, there are comfortable donor couches available at our center where the donor can lie down comfortably and undergo the blood donation process. Now, when the doctor selects the donor, as I had previously said, there are times when the doctor advises the donor not to donate blood. It either can be for a particular period of time called as a temporary deferral, or maybe the donor is asked not to ever donate blood, that is a permanent deferral. So I would like to enumerate some instances of temporary deferral. That is when a person is suffering from any disease, is on any medication, who's had a recent surgery, has been recently vaccinated, menstruating, pregnant females who are breastfeeding, have had a recent delivery, LSCS on an abortion, or those who might have had a recent tattooing. Now, who cannot ever donate blood? So any individual who is HIV, hepatitis B or hepatitis C positive ever in life, having cardiac problems, epilepsy, history of cancer, chronic kidney disease or liver disease, have had a transplant, have bleeding tendencies or hemoglobinopathies, have suffered from venereal diseases, are asked not to donate blood ever. This is our blood donation form. You can see that we keep all the demographic details of the donor. It also includes a detailed questionnaire, and also we have an option for self-referral over here. Post-donation care is of utmost importance. In this picture, you can appreciate the post-donation care instruction pamphlet. We have it printed in English and Hindi both. Also, it is displayed in the donor recovery area. It includes instructions to the donor, which are rest for 15 to 20 minutes, plenty of fluid, no heavy work or smoking, should be given refreshment. We are giving refreshment in the form of coffee. Continue with daily routine work, avoid strenuous exercises for 24 hours, do not drive for at least half an hour, and contact immediately in case of any discomfort or after the donation. Consent. Consent is a legal requirement of medical practice and not a procedural formality. Getting a mere signature on a form is no consent. We should strive towards explaining the donor or the patient the procedure that they are going to go through, the importance of it, the risks associated with it, the benefits associated with it, the other options available, and also an option to opt out of the procedure. After that only the consent will be termed valid. And this should be explained in the language best understandable by the patient or the donor. Consent forms available with us are for consent for blood donation, consent to test the donors for transfusion transmitted infections and notification to the government, for patient before transfusion, for therapeutic phlebotomies, therapeutic plasma exchange, granulocyte collection, peripheral blood stem cell harvest. These are the pictures of the consent forms that are available. These are both printed in English and Hindi. Now we know that after the blood donation is done in the form of whole blood. From this whole blood, we can make the components in the form of red cells, plasma and platelets. From the plasma, we can make fractionated products, that is like factor 8, factor 7, factor 9, albumin and immunoglobulins. And from this plasma, we make fresh frozen plasma. From fresh frozen plasma, we can make cryoprecipitate and the stored plasma. This is a picture of the blood bags that we are using at our center. This is actually a picture of a penta bag with leuco filter attached to it. It cannot be seen in this picture. Other than this, we are having other bags also. We have single bag, double bag, triple bag, quadruple bag, and also this penta bag we are having. These are the pictures of the completed product. The first one being LDPRBC or leukodepleted packed red blood cells. Next one is fresh frozen plasma, and the last one is platelet concentrate. You can see that these products are well labeled. It contains the barcode, it contains the blood group, and the RH is well labeled. It's got the product name, the product volume, the date of collection, the date of expiry, and also the testing status of this particular product well labeled. Now we know that we come about this term random donor platelets and single donor platelets. So random donor platelets and single donor platelets are different. Random donor platelets are those platelets which are collected from the whole blood after making the components, and single donor platelets we require a live donor to come and donate through the process of apheresis. And you can see in this picture on the left there the process is going on, and a single donor platelet is equivalent to at least 4 to 6 RDPs, and it takes about 5 to 6 hours for the whole process to be completed. You can see on the left, this is a final collected product, well labeled final collected product. Irradiated products. Many a times patients require irradiated products. This is to avoid transfusion associated graft versus host disease. Patients who are immunocompromised under chemotherapy, post-transplant patients require these products. The picture that we see here is that of an irradiation strip. This is color indicated. The red part that you see where not is written, this changes to black color. You can see in this picture here on the lower half, the color has changed. Actually, this changes once the irradiation process is complete. This is done either through gamma rays or it can be done through X-rays. Now, as we know, there are different components, and different components have a different shelf life and different storage conditions and different transfusion criteria. And very briefly, I would like to explain this. Whole blood, packed red blood cells and leukodepleted packed red blood cells all are stored at 2 to 6 degrees centigrade, and all must be ABO compatible and cross-match compatible before transfusion. Their shelf life depends on the anticoagulant and additive solution that has been used. If CPD or citrate phosphate dextrose is used, the shelf life is 21 days. If CPDA or citrate phosphate dextrose and adenine used, then the shelf life is 35 days. And if sagum or saline, adenine, glucose and mannitol is added, then the shelf life increases to 42 days. Now, fresh frozen plasma and cryoprecipitates. Fresh frozen plasma and cryoprecipitates in the 65 days or 1 year. Fresh frozen plasma needs to be thawed before transfusion. Once thawed, it should be used between 24 hours if stored at 2 to 6 degrees centigrade. The storage in which it is stored is between minus 25 degrees centigrade to minus 40 degrees centigrade. Cryoprecipitates, once thawed, should be used within 6 hours if stored between 2 to 6 degrees centigrade, and they are stored at minus 18 or below. Both fresh frozen plasma and cryoprecipitate should be ABO compatible before transfusion. Now, as I had discussed, random donor platelets and single donor platelets both have a shelf life of only 5 days. Both should be stored between 20 to 24 degrees centigrade with continuous agitation. We have dedicated platelet agitators where we store our single donor platelet and our random donor platelets. Random donor platelets while transfusion should be preferably group compatible. However, non-specific platelets can be given, and single donor platelets should be ABO and RH compatible and HLA matched when indicated. Granulocyte collection also is done at our center. The granulocytes shelf life is of 24 hours when stored between 20 to 24 degrees centigrade, and they should be ABO and RH compatible, HLA matched and usually irradiated. Thank you very much. I would now request Dr. Jay Fulwani from the Department of Medicine to please come forward and take this session.
Thank you, Dr. Nisha. A very good morning to all the esteemed faculty members. Taking the presentation forward, as we know that the different blood components have specific indications, we will be discussing them one by one. First one is the whole blood. Whole blood is indicated for symptomatic anemia patients that have large blood volume deficit, and it is also indicated for exchange blood transfusion in the newborns. It is not indicated for severe chronic anemia patients and coagulation factor deficiencies. Packed red blood cells are indicated for symptomatic anemia patients, both acute and chronic, for restoration of the oxygen carrying capacity of the blood, or when the hemoglobin is below a given threshold level, that is below 7 grams per DL when the patient is hemodynamically stable but is symptomatic, less than 8 grams per DL for orthopedic and cardiac surgeries, and less than 9 grams per DL for acute coronary disease. It is not indicated for nutritional anemia like iron deficiency, B12 deficiency, folic deficiency, and for coagulation factor deficiencies. Leukocyte depleted packed red blood cells are indicated for symptomatic anemia patients who require multiple blood transfusions like chronic kidney disease patients, oncology patients, aplastic anemia, sickle cell anemia, and thalassemia patients. Random donor platelets. These are indicated for thrombocytopenia related bleeding disorders, or when the platelets are below a given threshold, like less than 5,000 per microliter in absence of bleeding or infections, less than 10,000 to 20,000 per microliter if infection or risk of bleeding is present, less than 30,000 per microliter for disseminated intravascular coagulation with bleeding, less than 50,000 for major surgeries, lumbar puncture, invasive procedures, endoscopy, and less than 80,000 for neurosurgery, ophthalmic surgeries. They are not indicated for thrombotic thrombocytopenia purpura, immune thrombocytopenia, heparin-induced thrombocytopenia, and thrombocytopenia due to septicemia or hypersplenism, except in life-saving conditions. Single donor platelets are indicated for the same as that of the random donor platelets, but they have the best mode to correct thrombocytopenia by reducing refractoriness. Fresh frozen plasma, they are indicated for coagulation factor related bleeding disorders like massive bleed in acute hypovolemic coagulopathy like trauma or obstetric cases, for liver disease with bleeding that have abnormal coagulation test, for thrombotic thrombocytopenia purpura and disseminated intravascular coagulation. Cryoprecipitates are indicated for von Willebrand disease, hemophilia that have absence of factor 8, and for congenital or acquired fibrinogen deficiency. Granulocyte concentrates are indicated for severe refractory bacterial or fungal infections in patients with severe neutropenia, that is less than 100 per microliter. With the increased focus to practice evidence-based medicine, WHO has proposed for the patient blood management with the primary aim to improve the patient's safety and clinical outcomes by appropriately managing patient's own blood and by minimizing unnecessary exposure to the allogenic blood products. Patient blood management should be multidisciplinary. It should be patient-focused, evidence-based, systematic approach to optimize hematopoiesis in patients, to minimize the blood loss or bleeding, and harness and optimizing physiological tolerance of anemia. After knowing about the indications, counseling should be done before transfusion. Doctor must explain the patient relative about the need of the blood transfusion, its indications, requirements, pros, cons of blood transfusion in the language the patient or the relative can understand. The doctor must counsel about the transfusion options that are available and its expected benefits of transfusion, the risk of any adverse drug reaction or infections that can occur by transfusions. Patient or the relative can ask questions about the transfusions, alternatives of transfusions, risk of not transfusing the blood, procedures and the hazards involved. After sufficient discussion, consent is obtained and a requisition form is sent to the blood center. This is the consent form that is available at our institute, which is available in both Hindi and English. It should be duly signed by the patient or the relative and the concerned doctor. Now, after taking the consent, the blood requisition form is sent to the blood center. The blood requisition form must contain the details of the patient like the name, age, gender, name of the hospital, hospital registration number, ward number, bed number, name of the consultant, and the unit of the blood component that is desired. It should be duly signed by the doctor sending the requisition of the blood component and also by the person collecting the blood sample for the same. The vials sent should be properly labeled with the above mentioned information as shown. If the patient is reactive for any viral marker like HIV, HBsAg or HCV, the sticker is placed on the sample sent. If the information is not correctly mentioned on the requisition form, the blood center has the right to reject the requisition. And one form should be sent for one sample. So for specific requirements, according to the need of the patient, transfusion, specific requirements should be mentioned on the form that is sent. That is start requirement that is within 15 minutes with patients with active bleed, like in cases of road traffic accidents or massive antepartum hemorrhage, massive postpartum hemorrhage or ruptured ectopic pregnancies. Urgent requirement that is within 1 hour in traumatic postpartum hemorrhage or during OTs. Routine that is the blood is required after 2 hours during anemia or pre-op optimization. And reserved, that is the blood is not needed for the next 8 hours but needs to be reserved in the blood bank. In emergency situations or during disasters, uncross-matched O negative or group-specific red cells can be issued where there is insufficient time to wait for the complete compatibility report. It is a medical decision to transfuse uncross-matched blood. The below table shows which recipient can receive blood from which donor. Now, while collecting the blood sample to be sent to the blood center with the requisition form, positive patient identification is a must. It includes checking the IDs that is attached to the patient, that is the wristband, relying on the files, records at the patient bedside, or confirmation by third person is a passive identification and can be dangerous. Sample label should contain the patient's name, hospital number, name of the hospital, ward, date and time of collection. There are certain do's and don'ts that must be done while sending the request. Like those include always label the blood sample at the patient's bedside, label sample immediately before and after taking the blood sample. It should be a continuous uninterrupted process. Requisition form should be completely signed. Any discrepancy that occurs during the blood sample collection, resolve it before sending it for transfusion. Don'ts include don't sign for anyone else's work. Don't take sample from the arm in which there is intravenous infusions. Don't fill any wrong information on the form. Don't send any unidentified sample lying on the patient's bedside for transfusion requisition. To take the discussion forward, I would like to call Dr. Bhavya Thakur from the Department of Obstetrics and Gynaecology for administration of blood components.
Good morning, respected faculties. So after the blood transfusion consent has been taken and the requisition form has been sent to the blood center, the blood component is obtained from the blood center. The blood unit should be issued only when the transfusion is imminent, as once issued, the blood product won't be returned back. Always send demand slip to the blood center for the confirmation of the release of the product. The demand slip available in a hospital has been attached below. Transport from blood center to the patient area should be in well insulated transport boxes which maintain adequate storage temperature. Upon receiving blood unit, as patient location, details are cross-matched on blood unit accompanying compatibility report and patient records. Verify and explain procedure to the patient, ensure consent forms are signed, inform about side effects like dyspnea, chills, headache, chest pain and itching to the patient, and ask him or her to report to the nurse immediately. The baseline vitals are obtained before starting of the blood transfusion. Patient should not be left alone and frequent visual observation of patient for entire duration of transfusion should occur. As a very common reason for mismatched blood transfusion to patient is incorrect identification of blood unit or the patient. So while asking for blood from blood center, at least 2 unique identifiers of the patient should be matched, like the name and registration number of the patient. Any discrepancy should be considered an emergency and blood should be returned immediately to the blood center. As a second wrong blood transfusion might be about to happen. The information available on the blood unit, compatibility report and patient details are all cross-checked, like the unique unit ID, type of the blood component, volume, blood group. The blood unit is also checked for any signs of deterioration like clumps or leak present. The name and signature of the patient performing the compatibility testing should also be present. These are the stickers that are available in a hospital's blood unit containing the same information. The venous access, in routine cases, 18 to 20 gauge cannula is used for adult patients, and for pediatric patients, 20 to 24 gauge cannula is used. However, in emergency cases, large diameter and additional IV access may be used to achieve adequate flow. The blood transfusion set that we use for transfusing blood should be separate for different types of blood components. For example, blood transfusion set used earlier for packed red blood cells should not be used for platelets. Infusion pumps and syringe drivers are commonly used in neonates and intensive care settings. 2 different types of blood components are not advised to be transfused simultaneously. Example, platelets and packed red cells, even via separate IV access lines. This is to avoid any uncertainty arising in case of blood transfusion reaction. However, this rule does not apply in cases of emergency and life-saving situations. Fluids that are compatible with blood transfusion is 0.9% normal saline. Calcium containing electrolyte or colloid solution are incompatible as hemolysis can occur, and even with 5% dextrose, it's incompatible as hemolysis can occur. The rate at which the blood is transfused depends upon the clinical condition, age and cardiac status of the patient being transfused. For patient at risk of circulatory overload like hypoalbuminemia, cardiac failure, age above 65 years, the blood is transfused slowly with more frequent monitoring. It may be necessary to use a diuretic whenever indicated in such cases. The packed red blood cells should be started within 30 minutes of removing it from refrigerator, and it is finished within 4 hours. Random donor platelets and single donor platelets should be started immediately and finished within 15 to 20 minutes. Fresh frozen plasma and cryoprecipitate should be started as soon as possible and should be finished within 15 to 20 minutes. Now, for further observation and monitoring during blood transfusion and for various adverse effects that can occur during the transfusion, I would like to invite Dr. Sweksha from the Department of General Surgery to carry the discussion forward.
Patients undergoing elective surgical procedures often need red blood cell and other blood components intraoperatively or postoperatively. These blood requests frequently overshoot the actual need, resulting in unnecessary cross-matching. For the same, we have certain schedules that we follow to preserve blood components that may be needed intraoperatively or postoperatively during any major surgeries. These include maximum surgical blood ordering schedule, which is a list of common elective surgical procedures performed along with the maximum number of blood units being cross-matched pre-operatively. Surgical blood ordering equation includes patient and surgery specific variables such as preoperative or postoperative hemoglobin and the amount of blood loss during procedures. In our hospital, major surgical procedures like liver transplant requires at least 15 to 20 units to be preserved. For any kidney transplant, 4 plus 2 units are preserved, that is 4 for the recipient and 2 for the donor. For major vascular surgeries and CTVS surgeries, at least 4 units are required. When do we carry out these observations? At no point should the patient be left alone, and frequent visual observations of the patient for the entire duration of transfusion must occur. We start by taking vitals pre-transfusion to get the baseline vitals of the patient. This is followed by frequent monitoring of the patient at 15 minutes, 30 minutes, 60 minutes, 120 minutes, 180 and 240 minutes. The first 15 minutes are crucial as most of the transfusion reactions occur during this. At least 30 minutes after completion of transfusion, the patient should be monitored. What observations do we document? We start by taking the vitals of the patient, which includes pulse rate, blood pressure, saturation, temperature. Then we move on to look for signs and symptoms like wheezing, skin rash, itching, redness, shortness of breath, palpitations, chills, and rigors. All blood transfusions should be monitored and reported in the form as shown in the picture. We start by mentioning the patient particulars. This is followed by recording the date and time of the blood transfusion. Details of transfusion including type of blood, blood group, bag number, starting time, ending time, flow rate, any adverse reactions during transfusion should be mentioned. Vital signs before, during and after transfusion should also be recorded. Once the transfusion is completed, the form should be signed by the observer. What do we do if we suspect any reactions? We stop transfusion, maintain venous access, inform the duty doctor and nursing in charge. We check for the documents of the patient. We check and document the patient vitals and reaction. We recheck the unit details with the patient file. If we suspect any reaction, the following blood samples need to be sent to the blood center, which includes blood grouping, cross-matching, CBC, LFT, RFT, and urine routine to diagnose the type of reaction that has occurred. If required, we can also send blood culture of the patient. Along with these samples, we also send the blood unit along with the blood transfusion to the blood center to evaluate for the cause of reaction. Types of adverse reaction. These can be classified according to duration, time interval into acute and delayed. In acute, the signs and symptoms occur within the first 24 hours of transfusion. For delayed, the signs and symptoms occur after 24 hours to up to 28 days of transfusion. Types of reaction can also be classified according to pathophysiology into infectious, non-infectious, immune, and non-immunological causes. What is the difference between acute and delayed reactions? Acute transfusion reactions occur within 24 hours of transfusion, whereas delayed transfusion reactions occur after 24 hours to 28 days of transfusion. The main features of acute transfusion reaction include fever, chills, pain at the site of transfusion, tachycardia, hypertension, hemoglobinemia, and hemoglobinuria. Delayed transfusion reaction include fever, raised body temperature, unexplained decrease in hemoglobin or hematocrit. Major complications associated with acute transfusion reaction include DIC, renal failure, and shock, whereas for delayed transfusion reaction, anemia is the major complication that is seen. For prevention of acute transfusion reaction can be done by avoiding clerical and technical errors, whereas for delayed transfusion reaction, we should check the patient's record for recent transfusion or pregnancy. Thank you. I would now like to call upon Dr. Shweta ma'am from Department of IHBT.
Thank you, Dr. Sweksha. Good morning, all respected faculties. As today we have discussed about the criteria of donation, the importance of the consent and the request, and how to administer the different types of components. So I would like to comment that in India, the demand for the blood transfusion arises for every 2 seconds. On an average, 14.6 million blood is needed every year, and there is always a shortage of 1 million. Despite the technological advancements, there remains no alternative to blood, and 1 unit of blood can save as many as 3 lives. So for the safety purposes, always remember to send the sample with every new request, and always 2 identifiers at each point, and always transfuse the components whenever they are in. Avoid the unnecessary transfusions. So I would like to say at the end, I request everyone to join us to make our blood center to reach 100% voluntary blood donations.